Morning. All right. Ivana, are you joining us from Texas?
Can you hear me?
Yes.
Oh, yes. No, I flew back last night
Ah, okay.
and it was Georgia, Atlanta.
Ah, all right.
Saw Dr. Bonsall there.
Ah, Perna Bonsall.
Yep.
That's nice. How's she?
hmm She's great. And Dr. Shinoy also is doing very well. So it was great seeing them both.
That's nice. That's nice. I saw pictures of them online this weekend. Okay, we'll do a brief conference today. All right, this was online from Medscape. So this is like I can think of this like a board review question. An 11-year-old from Martha's Vineyard is being evaluated in an outpatient pediatric clinic for a low-grade fever and exercise intolerance on the soccer field, which presents as easy fatigue and generalized weakness. Her 12-lead ECG and the magnified rhythm below are shown. Until recently, she's been completely healthy, developing normally, has had no palpitation, chest pain, syncope, or exercise intolerance. There are no cardiac medications in the household. What is the next step in management? A, do nothing because this is a benign pediatric ECG finding. B, obtain an echo to evaluate for congenital heart disease. C, begin transcutaneous pacing immediately. Or D, obtain Lyme disease serologies. So why don't we go to Dr. Mukhopadhyay?
Good morning, Dr. Paz. Looking at EKG, I think she has a first-degree heart block,
Mhm.
and um, given the fact, I would like to rule out causes, even though I don't think it's something very ominous and it's going to, but I'm going to still rule out causes. I'm going to obtain Lyme disease serologies, do a thyroid function test, um, and after I rule out the causes, I would then feel reassured and not do anything.
Okay, so how are you ruling? What are you doing and how are you ruling things out?
So I'll send as option D. I'll do that. Then I'll send a thyroid function test. And these are common causes and um,
So your choice, so this is a multiple choice question. You're taking a board examination. You're choosing B. Is that your answer, your final answer?
yeah, it's D for donkey, yeah.
Wait, I thought you said B.
No, I said D. D for
Ah,
donkey.
D for donkey. Okay. All right. So the answer is D, obtain Lyme disease serology. This child presented with a first-degree AV block as evidenced by markedly prolonged PR interval 310 milliseconds. This is mostly a normal variant in pediatric population as a result of increased vital tone, particularly in runners. Asymptomatic first-degree AV block often requires no further workup or treatment. However, many congenital, infectious, immunologic, or toxicologic conditions may also cause prolonged PR intervals. This patient comes from an area, which is Martha's Vineyard, where Lyme disease is endemic. Can present with heart block ranging from first degree to complete heart block. In this patient, Lyme titers were positive, and she was treated with a course of doxycycline. Repeat ECG several weeks later demonstrated a return of the PR interval to a normal value. So, right. So if Lyme titers were negative, Katoki, what else would you do?
I would do a thyroid function test.
Right.
Uh,
Hypothyroidism can cause heart block. That's true for sure.
she's an 11-year-old female, but I've like still tried to rule out SLE because like lupus because that can also lead to a first-degree heart block.
Mm-hmm. Okay.
And uh, yeah, I would do these things.
Would you do an echo
Um,
or would you do any other blood work?
Probably not. I'll not do an echo.
Okay.
And
Well, I would actually do an echo in this circumstance because another possibility is a child could have myocarditis, right? From a virus or something like that. And if that's in fact the case, then you could have heart block and dysfunction. So it's a little weird, right, that somebody would have exercise intolerance from just first-degree heart blocks. So I probably would do an echo to confirm. You can have carditis with a bad function in the setting of Lyme also. So in other words, Lyme disease itself can cause dysfunction, although usually just a heart block and stuff. So I would probably get a CRP or an ESR, and I would probably get an echocardiogram. But that would not be my first step. My first step would be somebody, they're trying to make the point that if you're from Martha's Vineyard, which is, like similar to Lyme, Connecticut, it's an area that has a lot of, is known to be associated with spirochetes and Lyme disease. Okay. All right. All right, next question from Medscape. A 16-year-old male athlete is being seen for a physical examination before sports participation. The patient's electrocardiogram is shown. A focused history reveals that the patient has had palpitations in the past and an episode of near syncope, which he thought was due to overexerting himself. As a result, he never went to the physician for it and has never had a workup. In the event of acute supraventricular tachycardia, all of the following medications would be avoided except digoxin, procainamide, adenosine, and metoprolol. Let me go to Dr. Maya Kalis of Wisconsin.
Great. Good morning, Dr. Pass. So
Fresh from her vacation.
yes.
Brimming with energy.
So looking at the tracing, it looks like I see a shortened PR interval and a delta wave, indicative of WPW. And so in the event of SVT, I think all of the following medications should be avoided except. So I guess they're asking which medication should we not avoid. So I guess I would say C, adenosine.
So this is actually, let's go through each of them. So what about digoxin? Should that be avoided in the treatment of SVT or in someone with WPW?
I would avoid digoxin because I believe it can increase the conduction through the accessory pathway.
Right. So even though now it turns out that the question writer here is obviously an adult cardiologist, as you'll see from the answer. But the problem with digoxin is, as you just said, that it can enhance antegrade conduction. Now, if you're in SVT, which we in pediatrics think of as ORT mostly, theoretically, it shouldn't be that dangerous. It should, maybe slow AV node conduction. It might potentially terminate SVT. And in fact, if you did not have the 12 lead before and you were just in SVT, you wouldn't even know that the patient had WPW, and it was fairly routine that you would be giving before the advent of adenosine, which was really only available in the late 1980s or early 90s. Digoxin or even verapamil would have been given fairly regularly as an agent to terminate SVT. But I think that the reason you wouldn't give DIG is because of what you said, and theoretically, ORT can degenerate into atrial fibrillation, and then you could potentially put the patient up at risk. So that would be a bad choice. What about procainamide?
I guess I didn't think procainamide is necessarily something that you should avoid in the case of SVT with WPW, but perhaps it wouldn't be your first line agent in.
So this is very poorly worded. I don't agree with this question at all, which is why I showing it. No, Proc would be a perfectly reasonable agent. First of all, it causes pathway to slow, so it could absolutely be used to terminate SVT in somebody who's in SVT. But the other thing is it slows pathway conduction in general. So if the SVT were to degenerate into AFib, theoretically, it could protect the patient. So PROC would be a reasonable agent. Adenosine, I think in pediatrics, we would view, as you said, as the number one thing we would give to terminate SVT. And we'll see what the authors say. And metoprolol would not generally been used as an acute agent to terminate SVT. So let's see what they said. So they said the patient has WPW as evidenced by the delta wave, shortened PR interval, widened QRS. During atrial arrhythmias, drugs that block the AV node may augment conduction down the accessory pathway, which lacks the normal decremental conduction of the AV node. That would be, for example, why metoprolol would not be used. And in fact, in the adult world, beta blockers are generally frowned upon for the treatment of WPW because of that concern, that a patient could enhance accessory pathway conduction by causing slowing in the AV node. We don't actually believe that in pediatrics, but that is a fairly well-held belief in the adult world. During atrial arrhythmias, drugs, okay, so in atrial fibrillation or flutter, one-to-one conduction of atrial rates may precipitate fatal ventricular fibrillation. In stable SVT, adenosine may precipitate AFib and is best avoided. See, that's a statement that we would certainly not agree with. How's that water going there for you, Maya?
Sorry.
Of the drugs listed, procainamide has the least action on the AV node. However, if proc is not readily available and the patient's hemodynamic stability is in question, amiodarone is a reasonable alternative. So I think this is not a very good question. I don't think we would agree with many of the things that are written. And so really, I would say adenosine or procainamide would be reasonable agents for treating somebody who's acutely in SVT. It is true that if you give a very high dose of adenosine to someone, you can cause AFib. Some of you may have seen this happen in the cath lab when we're giving high doses during electrophysiology studies and testing. But generally speaking, particularly in children, it's very unusual to get AFib from adenosine, particularly at the normal dosing range. Okay, this is the last Medscape question. This is an EKG from a 15-year-old Asian male who's brought in by paramedics after experiencing a seizure during gym class. His 12-lead ECG is shown. The child has no history of seizure disorder, and he states he had palpitations before the seizure. The paramedics report their 12-lead ECG in the field was abnormal because their machine was reading it as acute myocardial infarction, but they were unable to identify a typical ST segment elevation. This ECG is consistent with which of the following abnormalities? WPW, Brugada, Epstein's anomaly, ARVC, or right ventricular cardiomyopathy, ARVC. So I'm going to ask Dr. Bezdakova what she thinks.
So looking at the EKG, it's in sinus rhythm, the PR interval appears to be appropriate. And then looking at leads V1 through V3, it looks like there is some ST segment elevation, and given the history of seizures and loss of consciousness, I would think that the EKG is consistent with Brugada syndrome.
Yes, I would agree with that statement. So the answer is B, Brugada syndrome. This ECG shows the characteristic changes of Brugada syndrome, a sodium channelopathy associated with the gene SCN5A, which is also, as you know, implicated in long QT syndrome. Christina, which type of long QT syndrome is SCN5A implicated in long QT also? I'll give you a choice. It's 1, 2, 3, or 4.
2.
Good choice, but wrong. It's long QT type 3 is a sodium channelopathy, SCN5A. It's a particularly bad kind of long QT in general. And so Brugada is more common in Asia. The ECG shows one of two ST segment morphologies in V1 through V3. The coved QRS, which is what's shown, consists of a right bundle branch block with a slowly downsloping ST segment. and an inverted T wave. The ST segment may also take a saddleback appearance in these leads with an upright T wave. That would be the type 2 version. Only AICDs have been shown to prevent death from arrhythmias in patients with Brugada syndrome. Although we generally ask that all fevers be very aggressively treated because fever seems to be associated with arrhythmia in this patient group. Urgent cardiac evaluation should be arranged. I'm not sure if it has to be urgent if the patient is awake and talking to you, but certainly it should be arranged. Yeah, if you have a patient who has this pattern and has been fainting, that probably would be an indication to consider an ICD in such a patient because we don't actually have any medical therapy for this condition. So just something to think about. And for those of you who are wondering what Yamaguchi syndrome is, I had to look that up. It's a form of hypertrophic cardiomyopathy that affects the apex of the LV predominantly.
Dr. Pash, just a question about this.
Sure.
So if he was asymptomatic and on routine screening had this EKG pattern, would you just follow or would you still electively place an ICD or do genetics first?
That's a good question. There isn't really 100% right answer. I think normally what we would do, first I would do an echocardiogram just to make sure that this pattern is not due to an RV volume overload, although it certainly doesn't look like a typical, incomplete or complete right bundle branch, but I would certainly do that. There's no harm in that. But assuming that that's negative, some people, first thing I would do is I would get EKGs at different times. So I might have the patient come back in 2 to 4 weeks to see what it looks like at a different time. But if it looked like this, I probably would at minimum do the genetic testing, which is, I believe at the present time, only positive about 50% of the time. But I would do that for sure. I would probably screen relatives of this patient as well and get a very detailed family history. But we don't normally, in an asymptomatic patient with a Brugada pattern, it would not be recommended that an ICD be implanted. Now, if you happen to have a family which had a history of Brugada with multiple people who've died suddenly, we would think differently about such a patient. But I used to take care of a boy who literally arrested at the funeral of his brother who had Brugada, and he had Brugada. So that boy got a defibrillator. But, in general, because defibrillators, as we all know, is not a free ride and there are potential side effects associated with ICDs, we would generally not just place one just because someone has this diagnosis, but one would have to take into account the history, the family history, etc. But certainly, though, it would be useful to get the genetic testing. It's sort of not helpful if it's negative, but it is very helpful if it's positive, just in terms of providing some guidance regarding risk. And there are recommendations from the ACC, AHA, and other organizations avoiding certain types of aggressive exercise. But one of the only really important ones is fever. It's interesting, this condition, which was described by the Brugada family, who are 3 brothers who are electrophysiologists, this condition actually was observed before they described it in Asia. In Southeast Asia, I think there were a lot of people. There was even a name for it before the Brugadas described it, something like sleeping death syndrome, or I forget what it's called, but essentially it was identified that there was a condition where not a lot, but there was a subset of patients in whom they died in their sleep. And that's characteristic of Brugada syndrome. Then it was determined that you don't have to be Asian, by the way, to have this condition, but it is more common amongst Asian patients.
Got it. Thank you.
Thanks. Good. All right. This is a 4-year-old with family history of seizures, and the patient themselves has had seizures and has seized 3 times. And you are asked to consult on this patient. So my question to you is, what is the diagnosis, and how would you consider working this patient up? I'm going to speak with Dr. Ivana Capin, fresh back from Georgia, where she learned a lot at the ACC.
Good morning. Okay, so looking at this EKG, overall, what stands out is the rate. So looks like the rate is sinus at about 45. When just looking at it on average, there is some kind of variability that you can see, and it looks like there are P waves prior to the QRSs, but I'd say overall the average heart rate is 45. So sinus bradycardia in a patient that's 4 years of age. Other than that,
I think it's quite that low. I think it's more in the low 50s, but okay.
Other than that, looks like there is a good AV conduction. PR interval looks appropriate. I think the QT looks somewhat long, but I'd have to kind of calculate it out myself. However, in the setting of seizures, that would prompt me for some prolonged QT type syndromes. Other things I would look at just quickly here. I think I would say the QT looks long overall, but again,
Right.
I have to calculate the number.
Well, I think the one thing I would say is, if you just look at this one, right, we can go from the end of the T wave, and we're still not even at the QRS at 400 milliseconds, right?
Yeah.
And then we have at least 3 more boxes. So this is at least 520 milliseconds, right? It's even longer, actually, if you take your calc, because it doesn't quite end at this hard box. It ends halfway into the next small box. So, sometimes there's a benefit to just looking at lots and lots of EKGs of normal and also abnormal. The point I'm trying to make here is, look at this very long isoelectric period, right, between the QRS and the T wave. This is a very late peaking T wave following a very long ST segment. This is just this in and of itself. Even if the QT interval were normal, the fact that there's such a long isoelectric period should give you pause when you're looking at it. And this is just an example of, now in this case, the QT is notably long.
Right.
Every lead, it's really, really long. Now we would have to correct it because the heart rate is actually less than 60. So the QTC is going to be a little bit lower than the measured QT, but this QT, in this, this looks like it's about 580, right? Because the QRS is starting right on the dark line, and it's going out to maybe just shy of 1 box of the third, so it's almost 600 milliseconds. So this is a notably long QTC, probably in the 550 range when corrected. Okay, so the patient has seized 3 times, and so what do you want to do for this patient? You think you've made the diagnosis of long QT syndrome.
I just had one more question prior to that. Do you make anything of the Q wave in lead 1? Would you consider that deep at all?
No, not really.
No. Okay.
I think it's okay. It's a little abnormal, but I wouldn't. You mean like it's indicative of an infarction pattern? You mean, or something?
Or like I was looking at one in the ABL just to see if there's any kind of Al Kappa like pattern, but other than that,
I mean, Al
kind of
Kappa,
borderline.
yeah. I mean, always something to think about, but more of a concern in young infants. This child is 4.
Okay.
And certainly, we would usually get an echo just because anybody who's having seizures, which can be anything really, you'd want to know that the heart is normal. I should tell you the echo was normal on this patient.
Okay. In terms of what I would do for a workup, I think I would work him up for a congenital kind of prolonged QT syndrome. I would specifically, I believe the Jervell-Lange-Nelson one is more so associated with seizures versus syncope, but I could be incorrect. And also I would do a family history check to see if anybody else has had evidence of sudden cardiac death or anything of the sort. Also looking for deafness or anything that kind of runs in the family with Romano Ward, which is another.
So nobody is deaf, and there's no one else in the family who has ever died suddenly or has seizures.
Okay. And then we've done an echo already, correct?
So would you do genetic testing in such a patient?
I think I would.
Yeah, I think I would too, because first of all, you'd want to confirm the diagnosis.
Mm-hmm.
And we know things about different forms of long QT in terms of risk and such. So we'd want to do that. Now, what about the whole seizure thing?
I'd want to kind of further work that up, see if it's true seizures or if it's syncopal episodes.
That's right. So how would you do that?
So I think I'm not sure how comfortable I would be if this kid was in the emergency room, sending them home. I'd probably admit them and put them on telemetry. If it was in the outpatient setting, I would, bring them back in with a ZO and perhaps exercise them and see if we were able to identify anything.
Would you send this patient to a neurologist?
I would have the neurologist look at them, correct?
Yeah, I agree. I would certainly you could have two things. And actually, some of these genetic abnormalities can be associated with seizure, by the way. So, yeah, so you would, and so then you have a 4-year-old. And so let's say the story in this case is that the patient actually does have a seizure disorder. And, but you don't really know, you've never actually none of these have been witnessed. And you don't actually know if this patient is having arrhythmias or not, right? You could have a seizure disorder and also have arrhythmias. And is this a high risk long QT patient, low risk, medium risk? What do you think?
I would imagine his rate is so slow. That kind of concerns me in itself, but I don't know the exact answer, to be fair.
Sure.
I would say it's long QT 2 or 3, just kind of looking at the morphology of the QTC, but I don't know offhand which one carries the most risk.
Well, it's always of interest to sort of guess what it might be from the morphology, but I would caution you to not really read much into these morphology things. You know, if you read a little chapter or a paper on long QT, they'll show you that there's a certain morphology of one versus the other, and they're generally decent rules of thumb, but they're not hard and fast rules at all. And so it turns out this patient has like long QT 12 or something, you know, one of these really unusual variants. So the bottom line is that, you know, in a 4-year-old, on the one hand, so what constitutes low versus high risk? So there are many different things, but in terms of the QT itself, when patients have a QT that is corrected that less than 500, first of all, first statement, all people with long QT are at risk for serious life-threatening arrhythmia. They're all at an enhanced risk versus the general population. Second statement is that if the QTC is less than 500, you are in the lower risk category amongst a high-risk population of patients. So less than 500 is the lower risk in the group, still not zero risk, but not high risk comparatively. 500 to 550 would be in the sort of moderate, and then above 550 to 600 would be considered high risk. So this patient is probably in the high risk category. So the bottom line is there is no right answer about how to manage this patient. I think for sure some form of monitoring, whether it be multiple ZO patches or Barty devices or halters, to try and get as much surveillance of the rhythm as is possible would make good sense. Now, you might ask, well, if you're a high-risk patient, why not just put an ICD in? I mean, patient is seizing. They certainly have a very robust long QT interval, certainly be at high risk. And the answer is simply that it's a big deal to put an ICD in a small child. This would probably have to be an epicardial ICD with epicardial sensing lead. Typically, we would place a shocking coil either in the pericardial space or in the pleural space, and then place the device in the abdomen. It would require either a thoracotomy or a sternotomy to do this operation. Very big deal. And unfortunately, although those systems work remarkably well and have been demonstrated in many examples, many papers, to be effective in preventing sudden death in small children, the durability of those systems is poor. So typically, the coil that's in the pericardial or pleural space will often break over time as children grow, and also children are very active. It's not like putting it in an 80-year-old person who is not as active as somebody who is, a 4-year-old and is falling all the time and running around as 4-year-olds are apt to do. So, so basically, we would sort of want to drag our feet as much as we can in terms of putting an ICD in, unless, of course, we were forced to. So if we had documented Torsade on beta blockade, then we would be certainly worried about such a patient, and we might put an ICD in. But probably most people would heavily beta block somebody who has this condition, as was done in this case, as you can see with this very slow heart rate.
So this is after beta blockade, because I was like, his heart rate's so low as it is. Okay.
That's right. This patient is being beta blocked. And then, there are different approaches. One could also put in a link device, an implantable loop recorder, which would allow for as frequent as you want assessments of the rhythm, but would be recording the rhythm continuously, and might give the cardiologist a hint into subtle, unrecognized, clinically silent episodes of Torsade or ventricular tachycardia that could be a sign that you should be more aggressive about treating this with an ICD. There are different ways to manage this, but the bottom line is when you have a patient who has this ECG is a scary looking EKG. Not only is the absolute length, but the morphology of the ST T-wave segment is very AB normal. And one would want to be darn certain that the seizures are true seizures and are not mistaken as actual arrhythmia. Because when somebody's having VT or Torsade, they could absolutely faint. They could even seize with the hypoperfusion of their brain from an arrhythmia, and it would look exactly like a normal seizure. And so one has to make the distinction. This patient, unfortunately, has both seizures and has a long QT interval. And so is something that, needs to be, both aspects need to be aggressively managed and treated. Thankfully, on anti-seizure medication and on high-dose beta blockade has done very well so far. Okay, any questions about this case?
No, thank you.
I think we'll stop here. See everybody in a little bit, and have a great day today. Be well. Bye.
Thank you. Bye.